Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Today, we are diving deep into adult cardiac arrest resuscitation, and we're going to move well beyond the basics to look at the foundational chain of survival, some of the latest guideline shakeups, and the critical decisions that happen the moment a patient's heart actually restarts.
Yeah, it's such an essential topic because this is, arguably the one area in medicine where a system failure has the highest, most immediate consequence.
Right.
When we talk about cardiac arrest, we're really looking at that start clinical triad. The patient is unconscious, they've stopped breathing, and
they're pulseless.
Exactly, a complete lack of circulation.
And the sheer volume of this crisis it's just staggering. In the U.S. alone, we're talking about well over 600,000 resuscitation attempts every single year.
It's a huge number.
But here's the reality that, kind of cuts through all the heroism. Despite decades of work, overall outcomes remain.
Well, they're incredibly poor globally. The statistics are really sobering, and they are so location dependent. If the arrest happens out of hospital, what we call OHCA, survival to discharge is hovering around just 9%.
9%. Wow.
But that number jumps, and jumps significantly to about 23% if the arrest happens inside the hospital, or IHCA.
And that difference alone tells you that immediate system readiness and monitoring, they matter profoundly.
They matter more than almost anything else. But simply surviving to leave the hospital, that can't be the finish line. We have to talk about the quality of that survival.
Exactly.
We use ROSC, return of spontaneous circulation, as the first goal. We got the heart restarted, great. But the really meaningful endpoint is survival with a favorable neurological outcome.
Because post-cardiac arrest brain injury is the real driver of everything that comes next.
It's the overwhelming driver of both death and severe long-term disability. Look, we might fix the pump, but if we haven't saved the brain, the victory is, it's pretty hollow. This is the central challenge.
Okay, so let's unpack the foundational roadmap for this whole process. The chain of survival. It's a sequence of interventions, but it actually has two distinct versions.
That's a critical distinction. For an out-of-hospital arrest, the chain starts with the activation of the emergency response.
Calling for help.
Calling 911. But in the hospital, the chain begins a step earlier. Early recognition and prevention. We're trying to see the signs of deterioration before the arrest ever happens.
Intervening before they lose that pulse.
Ideally, yes. But no matter the environment, the absolute non-negotiable bedrock is basic life support, BLS. This is pure mechanics, not pharmacology.
And this is where precision really matters most.
It's everything. We define high-quality CPR very, very strictly. The goal is just to generate enough circulation to keep the brain viable. So we're demanding a rate of 100 to 120 compressions per minute.
A depth of 5 to 6 centimeters.
And critically, a compression fraction of at least 80%.
80%. So for every minute, you can only be off the chest for a total of 12 seconds. I mean, in the chaos of a code, that sounds incredibly difficult.
It is. It's really difficult, and it often requires feedback devices to achieve. We forget that even a 5-second pause for a rhythm check can cause a massive drop in cerebral perfusion. It's why we drill hands-off time constantly.
And full chest recoil, letting the heart refill.
Non-negotiable. The heart has to refill to pump the next time.
This mechanical foundation, it's the most democratic intervention we have. Bystander CPR is the single greatest predictor of survival for an out-of-hospital arrest.
It really is. It can increase the odds 2 to 3-fold. It just speaks to the power of immediate action. And right after that comes early defibrillation.
For those shockable rhythms.
For VF and pulseless VT, yes. AEDs have made this accessible, but even for us, the focus is still on minimizing that pause before and after the shock. Every single second counts.
Okay, so once BLS is rock solid, we transition to advanced life support, ALS. This is where we layer in more complexity.
Advanced airways, IVs, IOs, medications, right. Vascular access is usually an IV, but if it's tough, we go straight to an intraosseous line into the bone.
But none of these complex steps can be allowed to disrupt that 80% compression fraction.
That's the constant tension in resuscitation. The advanced stuff is only helpful if it doesn't wreck the foundation. Same with advanced airways like ET tubes. We have to be so careful to avoid hyperventilation.
Right, because that can actually decrease blood flow to the brain.
It can paradoxically worsen the outcome. It's a huge pitfall.
So while all this is happening, the search begins. ALS isn't just an algorithm, it's being a detective. You have to find out why the patient's arrested.
Exactly. While primary cardiac causes are common, especially out of hospital, non-cardiac causes are also frequent, particularly for in-hospital arrests.
And that's where the classic mnemonic comes in, the H's and T's.
It's the guide for finding reversible causes. The H's cover things like hypovolemia, hypoxia, hydrogen ion so, acidosis, hyperkalemia.
Hyperkalemia being the big electrolyte one.
The most common, yes, and hypothermia.
And the T's.
The T's are tension pneumothorax, tamponade, toxins, thrombosis, so a PE or a heart attack, and trauma.
That is a huge list to run through under that kind of pressure. How do you zero in on something like a tamponade or a massive PE quickly?
This is where point-of-care ultrasound, or POCUS, has become just invaluable. During that brief rhythm check, you can get a probe on the chest.
So you're not extending the hands-off time.
You can't. You get a quick look. You might see fluid around the heart for tamponade or a huge right ventricle suggesting a massive PE. These are things you can fix mechanically right now.
So once we've addressed those immediate mechanical problems, we turn to the next layer, pharmacology. And this is where, as you said, the biggest controversies are. Let's start with epinephrine.
Epinephrine is first line, 1 milligram every 3 to 5 minutes. For non-shockable rhythms, a systole or PEA, you give it as soon as you can.
But for shockable rhythms, you wait.
You wait until after the initial defibrillation attempts have failed, correct? The whole purpose of the drug is just to augment coronary and cerebral perfusion.
Okay, and this is where it gets really interesting because epinephrine lives in this sort of evidence-based contradiction. It helps in one area, but maybe harms in another. What exactly is the epinephrine paradox?
It's the duality of the drug. Its alpha-adrenergic effects cause vasoconstriction, which raises blood pressure enough to perfuse the heart and brain, and that's why it unquestionably increases ROSC.
It gets the heart started more often.
It does. The big Paramedic 2 trial confirmed this. It improves survival to hospital admission.
But, and this is the paradox is in the long-term results of that same trial.
Precisely. That trial, despite getting more people to the hospital alive, found no improvement in survival with a favorable neurological outcome at 30 days.
So more hearts restarted, but not more brains safe.
Exactly. The concern is the beta-adrenergic effects. They increase heart rate, increase myocardial oxygen demand, and that might just worsen the brain outcome in the end.
That's a profound implication for providers. So if our number one drug has this cloud over it, where did the research go next? Things like VSE, vasopressin, steroids, and epinephrine.
Right. VSE was investigated heavily, especially for in-hospital cardiac arrest. And some studies did show promising increases in ROSC rates. The steroids were there to try and blunt that massive inflammatory response post-arrest.
But routine use is not recommended now. Why the pullback?
Because the goalpost moved to neurological outcome. While VSE might get you more ROSC, the evidence was inconsistent when it came to long-term survival or critically good brain function. We prioritize interventions that lead to brain recovery, and VSE just hasn't definitively proven that link.
Okay, what about antiarrhythmics? Amiodarone, lidocaine for that refractory VF or PVT? What's the latest data there?
Well, the current consensus, solidified by recent European guidelines, is pretty stark. When you compare these drugs to placebo in large studies, none of them improved overall survival or favorable neurological outcome.
None of them.
None. They're still in the algorithm, amiodarone first, lidocaine as an alternative, but the message is clear. Pharmacology is secondary to the mechanics of great CPR and early defibrillation.
And all the other things we see, calcium, bicarb, thrombolytics, is the rule still specific use only?
Absolutely. Routine use of any of those is explicitly not recommended. They are reserved for very specific confirmed causes. Calcium or bicarb for confirmed hyperkalemia. thrombolytics for a confirmed massive PE. That's it.
The moment ROSC is achieved, the danger is far from over. The patient enters the post-cardiac arrest syndrome.
Which is a systemic catastrophe. You have ischemia followed by reperfusion injury, which triggers this overwhelming inflammatory response. You get hemodynamic instability, myocardial dysfunction, and all of that continues to starve the already damaged brain of oxygen.
Which brings us to a core strategy in that post-ROSC phase. Targeted temperature management, or TTM.
Right. TTM is recommended for any adult who gets ROSC but isn't following commands. Now, the target is a controlled, constant temperature between 32 and 37.5 degrees Celsius.
That's a wider range than it used to be.
It is. The big takeaway from recent trials is that while aggressive cooling was the old standard, the most important thing now is the prevention of hyperthermia.
Preventing fever.
Exactly. Fever in the post-arrest period is consistently and strongly associated with worse neurological outcomes and death. So the mantra now is precise temperature control, but always, always avoiding fever.
Okay, let's talk about a big sequencing change in post-arrest diagnostics, the imaging pathway. Historically, you suspect a heart problem, you rush to the cath lab.
This is a major update. If a patient gets ROSC and the ECG shows clear ST elevation, yes, emergent coronary angiography is the top priority.
Because a blocked artery is the likely culprit.
Highly likely. But, and this is the update, if ST elevation is absent, current guidelines suggest you should prioritize a whole-body CT scan over an immediate trip to the cath lab.
A CT scan first. Why?
Because without that clear sign of a heart attack on the ECG, the chances that the arrest was caused by a massive, non-cardiac surgical emergency just went way up.
You're hunting for those other T's.
Oh, you're hunting for a massive PE, an aortic dissection, something that needs an operating room, not a cath lab. If you take a patient with the dissection to the cath lab, you've wasted critical time and you're in the wrong place to fix the problem.
So it's about smart, rapid triage.
It's all about smart triage.
And finally, rounding out this whole chain, there's a new link. Recovery and survivorship.
This is a formal recognition that the journey doesn't end at discharge. This phase acknowledges the massive long-term needs, physical, neurological, cognitive, emotional, for both the patient and their family. It's about a return to life, not just restarting a heart.
Let's quickly touch on a few specific scenarios. Anaphylaxis-induced arrest. What's different?
Standard resuscitation applies, but the priority is immediate, robust administration of epinephrine. That's the root cause. And interestingly, new guidelines specifically recommend against routine corticosteroids during the arrest itself. No proven benefit in that acute phase.
What about post-cardiac surgery arrests?
Highly specific. They're usually witnessed on a monitor. If it's VF or VT, the provider does immediate defibrillation before even starting CPR. And you might have access to temporary pacing for bradycardia or a fistule.
And pregnancy. A huge physiological consideration.
A huge one. Standard ALS applies, but you must immediately modify it to relieve aortic hovel compression. You have to tilt the mother 15 to 30 degrees to the left to get that baby off the major blood vessels.
So blood can get back to the heart.
Exactly. And if ROSC isn't achieved quickly and the pregnancy is at or beyond 20 weeks, you have to consider a perimortem C-section within 4 minutes.
An incredibly high-stakes decision.
Incredibly.
This has been such a complete deep dive. It shows how the mechanical cornerstones, high-quality CPR, early defibrillation are just non-negotiable.
Right.
While the decisions around pharmacology and post-arrest care have become so incredibly nuanced.
That's the synthesis. Master the foundation. Then manage the complexity. That means understanding the epinephrine paradox, embracing TTM's focus on fever prevention, and knowing about that diagnostic pivot to CT when the ECG isn't screaming heart attack.
We've made huge strides in achieving ROSC, thanks to bystanders and rapid response systems. But the data keeps pointing back to one elusive challenge.
And that challenge is the profound prevalence of post-cardiac arrest brain injury. We can restart the heart more often now, but we haven't solved the damage done to the brain. And that's why long-term neurological function has to be the ultimate measure of success.
Which leaves a big thought for you to mull over. If we know that achieving ROSC doesn't guarantee a good neurological outcome, how much more emphasis should we be placing on that newest link, the recovery phase, in the next decade of research?
That's the critical question for the field.
Thank you for joining us for this deep dive into the critical chain.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.